So, Bismillah ar-Rahman ar-Rahim, Assalamu alaikum. I'm Dr. Hamid Sharif from Rawalpindi Institute of Cardiology, and I have the company of two eminent professors with me, Professor Tanvir Rab. He's from United States, and he needs no introduction, a lot of work in interventional cardiology. And with him is Professor Khursheed again, a very eminent professor countrywide. So what we are going to do, we are going to discuss provisional versus TAP. Yes, next over. So provisional versus TAP. As you all know, that when it comes to bifurcation stenting, a lot of thought process has to go before you go on to take the first step. And for that purpose, first of all, we will discuss the Medina Classification. It's a simple, straightforward anatomical classification which gives us an idea about the distribution of the main branch, the side branch, and the distal main branch. So as you all know, the proximal main branch, the distal main branch, and the side branch. And if it is 1, 1, 1, then it means that all the three vessels are diseased. At least they have stenosis at least more than 50%. So this is the criteria. For 1, for example, 0, if the lesion is less than 50% stenosed angiographically. And if it's more than 50% stenosed, we grade as 1. So if its proximal vessel is diseased, then it is 1. Its distal is diseased is again 1. And the side branch is again the third one. The first one stands for the proximal, the second one for the distal main branch, and the third one is for the side branch. So for true bifurcation, all the three vessels need to be involved. That is 1, 1, 1, this is the first one. 1 for the first 50% stenosis of the proximal branch, and then distal, and then the side branch. So provisional versus two-stent strategy is again very important for us to know when to do provisionally and when to do two-stent strategy. So the first thing for provisional strategy is, it is a planned one-stent strategy. And provisional doesn't always mean that you have to put in a single stent. You may end up putting in 2 stents depending upon your angiographic results of the side branch. So for provisionally, we first go and think of putting 1 stent. And if the side branch goes down, if it shows signs of dissection, less than TME2-3 flow, then we think of putting another stent in the side branch. It's still a provisional strategy because your thought process was to stent the main branch first, and side branch if it is needed. So for provisional side branch ballooning, pre and post dilatation if needed. Some people even don't, if for some of the vessel is less than 50% stenosed and the plaque burden is not much, you may not need to even pre-dilate the side branch. Just wire the side branch and see how it behaves. So it's not necessary always that you even balloon the side branch. You balloon the main branch, and if you feel that the side branch ostium is quite pinched, you pre-dilate it. But to stent it, it's the decision which will be taken later on. And then you always know it's a planned upfront strategy. When the vessel side branch is quite large, it has quite big area of supply, for example, a huge diagonal. Yes, mostly in the left main bifurcation, the circumflex is quite large, the side branch. It supplies a huge trajectory of myocardium. So you might think of two-stent strategy straight away in such cases. And if you go for two-stent strategy, leave it alone technique, okay, to wide side branch, but others, wise do not touch it unless it occludes, no pre and post ballooning. And secondly, as I just said, you may end up putting another stent as well. So coronary bifurcation is not simply Medina, it is beyond Medina as well. This is important because we need to know about the side branch, the area it supply and the degree of stenosis of its ostium. And also the length of the lesion is very important. So this Medina classification doesn't help us in telling about the side branch behavior, the myocardium it involves or it supplies, and also the degree of stenosis, the calcification involved, maybe it may be thrombotic, maybe it has a huge lesion. So that's very important for us to know the side branch. That may alter our decision first up that we may go for a two-stent strategy even in non-left main diseases. If the side branch is quite large, ostium is more than 60 to 70% diseased, and its length is more than 10 millimeter. So this we comes to, based on this was a definition criteria by Chen et al. It was a paper in 2015 in which he defined the side branch or the definition of a complex side branch. It entails that the side branch has to be more than 2.5 millimeter, and it has one major criteria, which may be a left main branch with side branch more than 10% and more than 10 millimeter and more than 70% stenosis when it comes to the circumflex of a left main bifurcation, and more than 90% stenosis elsewhere. For example, the diagonal or the OM branch, if it is the side branch, or even if it's the PDA branch. So this is what we know, the complex bifurcation lesions. In complex bifurcation lesions, it's better off, as they say, based on the studies, that is, you go upfront with a two-stent strategy because the side branch is big, 2.5 millimeter. It is calcific. It has a large disease in the proximal course, more than 10 millimeter. So you may think of going for two-stent strategy in such case. Not always, but mostly. So this is DK Crush 5, Chen et al. Again, 2017 paper. If you can see, there are two kinds of lesion, the simple and complex. And the simple lesion comprised 64%, and 36% comprised the complex lesion, and more than 80 to 90% of such cases ended up with two-stent strategy, which was a DK Crush. And mostly in the simple strategy, they went with the provisional approach. So what is the degree of we have so many studies about bifurcation stenting, starting from the Cactus, the Nordics, the BBC ones, and then the latest ones like the EBC main. If you look at all these trials, what is the percentage of side branch occlusion? For example, if you're going with a proximal stent, one always thinks about what if I may lose the side branch. So in all these studies, we can see if the side branch originates from a lesion in the main branch, but is normal, or has stenosis less than 50%, there is less than 2 to 4% chance of side branch occlusion. So it's very less. All the more reason to go provisionally. If the ostium has more than 50% stenosis, it rises from the main branch, it is big, the risk is again not more than 20%. It is 4 to 18%, up to 18% in complex bifurcation lesions. So the degree or the percentage of stenosis of the side branch is still less, even in the complex PCI. So it has to be very much meticulous decision whether you go for a two-stent strategy upfront or provisional strategy upfront. And even, for example, if the side branch goes down, we have certain bailout techniques as well if you go provisionally as well. So a different number of factors angiographically. So this is all planning. You're looking at the angiogram, you're seeing whether I should go two stents, one stent. You look at the side branch, you look at the degree of stenosis of the side branch, you look at the size of the side branch, whether it's 2.5, less than 2.5. You look at the ostium of the side branch, whether it's more than 90%, less than 90%, the length of the side branch. All these things you need to know. And another important thing is the angulation. If the angulation is less than 45, access to side branch may be easy, but cranial shift is more pronounced. So more 45 degrees, more close to the main vessel it is, the more chances of it is getting. If the angulation is more 70, the access is much easier, but canal shifting is minimal. So if the angle is quite narrow, the access might be difficult, but it's much easier for the side branch not to occlude because the cranial shift, I will tell you about what cranial shift really is in later on. If you can add, you're more than welcome during the course of the talk.
So can I add now?
Thank you. So we'll be going on stepwise, like just you said, when to side, when to wire, when not to wire, when to balloon the side branch, not to balloon. In the due course of the lecture, we will go through the steps, and then you can enlighten us upon those steps as well. So for true, non-true bifurcation, true bifurcation, and specifically for complex true bifurcation, these are quite a few studies that I went across, and I just was very surprised to see that in most of the studies, for non-true bifurcation, for example, the side branch is not involved, leave it alone strategy was good, just as Professor Tanvir said. For example, if the side branch is not involved, you just keep a wire in it, and you don't need to stent it. You don't need to recross, you don't need to balloon, you don't need to kiss. That's not needed. Even in the cross-Korean trial and Nordic 3 trial, leave it alone strategy in which it was only wired, and very sparingly it was ballooned and kissed. The results were quite good. When it comes to true bifurcation, even involving the left main, for example, it was 111, and it was non-complex, just as I said, it is less than 2.5 maybe, and if the side branch is not much involved, in the perfect Nordic 4, EBC2, and even DK Crush 2, for the simple lean, a provisional strategy, often with ballooning of the side branch. Now, since we come to the left main, the side branch can be quite big, so we may end up doing a kissing balloon inflation. In such cases, just a simple kissing balloon to end up the procedure with, it has the same effect as the planned two-stent strategy. For example, the MACE is not different. The angiographic restenosis over a period of 1 year is same as that of the two-stent strategy. Only in specifically for complex true main lesion, especially involving the left main. In the two trials, Definition 2 and DK Crush 5, they're both Professor Chen's trials in which the DK Crush was extensively used. And in these days, we saw that the upfront two-stent strategies is preferable over a single stent strategy. Apart from that, for example, if it's a non-complex left main, for example, it is a true bifurcation, non-true bifurcation, A provisional strategy always holds good and has got equivalent result, even better result in most of the trial compared to the planned two-stent strategy in such cases, as was discussed in all these trials. So it's much easier, or it's much important for you to consider provisional strategy in a non-left main, non-complex bifurcation lesions, and it has got a very good results over a period of time. So the 7 questions that you always ask yourself when you are starting a bifurcation lesion: number 1, wire side branch or not? Just as Professor Tanvir said, whether we should always wire the side branch, we should keep it away. For example, taking another wire is always helpful, but should we routinely wire the side branch? That's the question. The second question is that, should we go provisional side branch stenting versus upfront two-stent strategies straight away? That's another question that comes into your mind. And all those trials and all those anatomies and all those side branch morphologies, the length of the lesions, 2.5 millimeter, the angle, that comes in your mind while deciding whether you should go upfront two-stent strategy or not. The third question, should we predilate the side branch before main branch stenting? The next question is that, should we provisional, should we post-dilate the side branch? In provisional, when to provisionally stent side branch after main branch stenting? That's a very important question. For example, if the side branch goes down, what are the criteria for us to recross and to extend again, doing a tap maybe, or a reverse crush, or a cure lot for that purpose? What are the options that we have, and when to do those? That's another question that bangs your mind when you have committed to the provisional stent strategy. In provisional stent, if stent needed, what strategy? And in two-stent strategy, what stent strategy? So these are the questions. So the first question, should we always wire? Well, the trials in the says it's always safe to wire the side branch. If it is very small, non-significant, less than 2 maybe, you may leave it. In all other cases, it's always preferable, as Professor Tanvir said, it's always preferable to wire the side branch. It has got a lot of help because we can see the wire reduces the risk of side branch occlusion following main branch occlusion stenting and can be used as a marker in case of occlusion. So that is the first benefit. Number 1, the presence of a wire in the side branch always helps prevent a side branch occlusion. In approximately in the TULIP criteria trial, it was seen that the presence of a side branch reduces the occlusion of side branch compared to not keeping it up to 1/3 of the cases. And again, it helps us access the side branch because it acts as a marker. And for us, it's because at times the artery may get shaved off. You may not be able to see the entry point. So that wire may help as a marker to re-enter the side branch if it is needed.
There was a large study just published in March from Korea that over 2,500 patients showed that if you wire the side branch, there was more patency rates are higher.
Yes.
Not wire. So that question's already been answered.
Yes, sir. So the first question, yes, if true bifurcation with side branch more than 22 millimeter, yes. On not a true bifurcation, but side branch still more than 2 to 2.5, always. My thinking is that we should always keep the side branch patent by putting in a wire in it. It doesn't need to cost you much. Taking another wire, maybe a BMW, and just put it in the side branch to improve the patency, as Professor Tanvir said. And secondly, always act as a marker later on if you need to recross. So provisional side branch stenting versus upfront, we went across all those trials. Provisional whether true bifurcation or not true, two-stent strategy only for true bifurcation with large side branch, extensive and complex disease beyond the ostium, as in distal left main, and with long and complex circumflex disease at times. If it's a dominant circ with a large OM issuing, if it's a large disease at the ostium of the OM branch and more than 10 millimeter, it's better that you go up front with a two-stent strategy. The third question, in provisional predilate side branch or not before main bind, often yes in true bifurcation. Again, if the side branch ostium is involved, more than 80%, 90% disease, it's better we predilate it. But which balloon would normally use for predilation of the side branch? Is a normal balloon or a non-compliant?
I use a very small, generally compliant balloon.
Okay.
If I need to. Generally, I will not predilate the side branch.
Oh, side branch, okay.
I tend not to do that. I tend to plant my stent and do a pot.
Okay.
And sometimes you'll be very surprised that the struts open, side branch opens up, you don't have to do anything.
Open it.
But if you have to predilate, if it's calcified or you cannot recross, it's a very small.
And you would tend to do a submaximal to avoid any dissection?
Yes, the big problem with side branch dilatation is you can cause dissection. And
Okay, yes.
if I rewire, it will be a real problem.
So it's very important. For example, if it's a calcific lesion, it's a long lesion, there is a risk of dissection. If you have committed to two-stent strategy, you dilate submaximally and see how the flow goes. It's better to go gradually up rather than going once the whole up and then you see the dissection. You cannot difficulty in assessing the side branch, just as Professor Tanvir said. So it's better that if we have to, if you are going with a provisional strategy, we wire the side branch, and if we think there's quite a bit of a disease at the ostium of the side branch, it's calcific, we just dilate it with a semi-compliant balloon, a small balloon, and gradual dilatation to avoid any no reflow or any dissection in that vessel. Only if you're, yes please.
No, and underdilate, okay? And then the other thing is, if you have cutting balloons available, for example, I tend to use a cutting balloon, small 5mm, 6mm cutting balloon, because it is a controlled dissection, okay? And there's a small study done, I don't know if the angiosculp balloons are available in this country or not, but a small study was done that would angiosculp the side branch and then pull out that device and then stent the main vessel. And it actually was a positive study. It was not published in trial. But you have in this country an advantage that you have drug-eluting balloons available, to take care of the side branch issue. But I think you want to pre-dilate gently with smaller balloon size, just to keep it open and not to dissect it.
Yes.
Once you have a dissection, you'll have to stent it, and that's a problem.
In case someone wants to gain the two stents strategy, so when to go for the one size with NC pre-dilatation of the side branch?
Yeah, you want to make sure that your stent will expand well. So if your strategy is that you want to make sure that there's no waste there, okay? I try to undersize the balloon a little bit, and then I want to make sure there's no waste there, because I know that if I put a side branch stent as the initial strategy, I'll probably get away with that.
Yes. So to answer your question, just to add on it, if you are thinking of a two-stent strategy up front, for example, and it's definitely a sizable wire, Professor Tanvir's points are quite valid, but if you have an IVUS at hand, it's better to do an image if it is able to, and then you have to come to know about the extent of the calcium, whether you need a cutting balloon or an angiosculp or maybe a rota at times. So that is very helpful, because if it's a sizable side branch in a complex lesion, long length, calcium involved, it's better to image if you're going with an upfront two-stent strategy. That is why I'm saying that the choice of the case, the selection is very important. If you're committed to a provision strategy, then you must keep in your mind that you have already ascertained that this vessel is not that big. And as just Professor Tanvir said, if you're going provisionally, he hardly pre-dilates the side branch because he thinks either it is quite small to be pre-dilated or the lean is not that extensive or significant for that. And as I said, when you put up a stent in the main branch at times, the flow in the side branch automatically improves in most of the cases, and you get a better result.
Yeah, if you do a pot, okay, so if you take an LED, 3/0 distillates, 3/5 proximally, take a 3/0 stent across the side branch, take a 3/5 balloon for pot, you'll see the stent stretch sometime, just go to the side branch, okay? If you're just before if you have the marker, just at the diagonal, okay? You'll see stent stretch open. If that's the case, you'll be okay.
So this is the point 4, as he said. If it is a true bifurcation, pot, rewire and post-dilate the side branch. And if it is more than 75% after main branch stenting only. If the lean is less than 75% narrowed, you can still leave it. It may look that it is more than 75%, knowing it more look, but as you said, if you study later on, the FFR studies have shown that it's still not significant most of the times. I will just discuss later on.
If flow is good, I'll leave it alone.
Exactly,
okay?
flow is good.
Flow is good, I'll leave it alone.
Because, yes.
And if after you look at two different angles, just don't look at an epicranial, look at caudal view, you'll see that was an eccentric plaque shift. You come back months later, you will not see that anymore. You should give nitro to take a final picture. But ideally, flow is good. Unless the dissection to me flows less than 3, or and the patient have an active chest pain, I leave it alone.
Maybe unless it is a left main case and it's a
this is a non-left.
Non-left main case. So this is what. If it is a left main case and you're going provisional, and if you're more than 70% stenosis in the circumflex, it's better you go with the case first and then think of putting the stent if required.
Circumflex is more important than diagonal.
Yes.
Obviously,
Compromise. Okay. So in provisional, if stent is needed, which strategy? So these are the 3 strategies: the provisional tap, we have the Q-Lord and the reverse crush. We'll discuss it later on. In modern trials of true bifurcation, when they went provisionally, they ended up with tap in most of the cases. So the tap is the preferred technique when you have for the bailout stenting of the main. For example, if you stented the main branch, it's better we go with a tap. Rather than going with the QLOD or the internal crush, I will just study in detail in the next slides as well. So bifurcation with a side branch of less than 50%. So this is the algorithm. If the side branch is less than 50% involved, you double wire only if the side branch is more than 2, or routinely double wire I would suggest. Do not pre-dilate side branch, not needed if it is more than 50% stenos. Do not post side branch unless the TIMI flow is less than 3, as Professor Tanvir said. And even if it develops stenosis more than 75% of the balloon, if the TIMI flow is good enough, there's no dissection, as pointed out, you don't need to chase it. Except in left main cases, which is a total ball game altogether, because circ is definitely a big vessel. So why at times we see that the side branch has gone down, there's ostial pinch, and at times the FFR is negative, and at times the patient does well in studies, it's because mostly the patient have 2 or 3, which is the Karana shift. For example, it's always said, you size the balloon to the distal artery, to the distal main branch. It's not always, you size to 1 to distal branch, the pre-dilatation balloon. This is because if you look at the third figure, if you size to the proximal vessel, the distal vessel, as you know, for example, in most of the vessel, the LED, it tends to taper. So if you size to the proximal, the distal main, the lateral wall of the distal, close to the side branch, it tends to shift towards the lateral. There's no plaque shift, but the Karana altogether shifts, and this is only a functional stenosis. It's not a, for example, it's a 2D structure angiogram that we are looking. As Professor Tanvir said, it's always better to look into other orthogonal views as well to ascertain this. So if we size the the balloon, the pre-dilatation balloon, to the proximal vessel, the distal, because it is smaller compared to the proximal, it tends to move towards the side branch, and it causes Karana shift rather than the plaque shift. If it's a true plaque shift like this above, then there is a slow flow effect, then can be problem. And even in those cases, only if the TIMI3 flow is compromised, the TIMI flow, you go on to post-dilate and case and maybe stent if needed. Only if the TIMI flow is compromised, even if it's a small vessel with a bit of a compromised TIMI flow, you can even still leave it. But if it's a large vessel, TIMI flow is compromised, there's dissection, it's better to chase it.
Just one point, that make sure that you have enough length of the stent above the diagonal. You'll be pleasantly surprised if you come back and pot, okay, with a 6 millimeter, 8 meter balloon. Tip of the pot balloon should be right to the ostomy diagonal. You're pleasantly surprised that the coronal shift will go away.
Yes, that's a very important point. And when you are planning a procedure, you always make sure that you have smaller balloons available. For example, if you are doing a left main, and if you're coming across, if the left main size is small, and if you think of a pot, you have to go to the shelf and see if you have 6 or 8 balloons available, because you won't take a larger balloon so as to cover the Karana of the side branch. So it's very important for you to see the inventory as well and see if you have all the size balloon available as pointed out. So this is the same algorithm which is going on. We studied the simple true bifurcation, the provisional stenting. If there is residual or worsening side branch more than 75 to 90% with compromised TIMI flow, we rewire, we post-dilate, the side branch, we perform kissing balloon. Only if there is persistent more than 90%, even at times you sit there, give some nitrates, give them some glycoprotein 2B3 inhibitors if the side branch is going down. And even still at times you see much better results. And you have all the reason to stop over there rather than chasing that side branch and making your procedure more complex. So stop there, and only if it is persistent side branch occlusion more than 90 degrees, the patient is having signs of hemodynamic compromise in the form of chest pain, falling blood pressure, TIMI3 flow is decline, dissection, then you chase the side branch, because then it shows that side branch is quite significant and it needs to be chased.
You just need 3 wires in your armamentum. Okay. BMW is pretty good. Then what we have is a run-through wire. I don't know if it's available here or not.
Yes, it's available.
And pilot 50. You just need those 3 wires, maybe a whisper wire.
Okay.
Not more than that. But generally, a run-through or a whisper will get you back in, provided you give the appropriate hook and angulation.
Okay.
You've got to push the wire through, then pull back, then try to torque it.
So talking about the wires, we can discuss the steps of the provisional technique, and if you can let us know which wire would you prefer in which part. For example, first of all, you wire the main branch and the side branch. Would you take same? I
take 2 different wires.
Okay.
I don't want to get confused, and so I either would take a run-through or one branch of BMW.
Run-through or BMW, the normal workhorse wires would do good in both cases. So wiring the bone, yes, please.
But you've got a wire there as a marker, you see? So a wire there as a marker, even if we occlude, you can generally find your way back. Because if you don't have a wire there and a marker, you'll just be, you know, you call futzing around trying to find a place to be.
He's talking about the pre-dilating the side branch.
I prefer not to do pre-dilatation. Most of us will not pre-dilate.
If you're going with a provisional strategy, it's better not to pre-dilate. So, for example, committed to a two-stent study, and obviously you're committed to putting in a two-stent, you have to pre. If you're going with a planned provisional strategy, it's better just to keep a wire in, but not to pre-dilate, because you don't want to make things worse for you from the outside, because there may be a dissection, there may be a compromised TIMI flow in the side branch from the outside, and your plan is going to go haywire. So it's better you wire both branches, and you just see how it behaves when you are treating the provisional strategy.
I tell you, I've always regretted when I've not wired, okay? I mean, I'll tell you that. But it takes a little bit more time, and you may be in a rush, but that's an essential step. And that's been proven through a trials, pre-wired.
Okay.
No, I try to use the same run-through wire if I can get in. If I can't get in from that, then I'll probably get a pilot 50. It always crosses.
Okay.
You have to make a double bend on that.
So we'll discuss it. First, we wire both branches, and we balloon or pre-dilate the main branch, and we do a pot. For example, in this case, just in case, for example, we pre-dilate and we put in a stent. The fourth one is the stent, and we do the proximal optimizing technique, as Professor Tanvir rightly pointed out, that you have a sized balloon. You should have that size balloon which doesn't cross the ostium of the diagonal of the side branch. It doesn't go all the way down across the side branch. It just covers the proximal portion of the side branch, and you pot it, and only if the flow in the side branch is compromised, you recross it. So talking about the recross, so you go with the BMW or the run-through.
Yes.
Only you go with a hydrophilic polymer jacketed only if there is difficulty in recrossing.
That's correct. I mean,
Okay.
you don't generally recross. And the other thing is, you'll be pleasantly surprised once you do a pot, how easy it is for the wire
Yes,
to go
because
back in. And also that you can push in a balloon of the adequate size to go through. You can nudge it through, but it has to be
Yes.
a fresh balloon, okay?
So the importance of pot is not to avoid the other branch going behind the stent. It also opens up the struts across the side branch, and it helps you redirect your wire into the side branch. And for a provisional technique, other than the crush, you always try to cross from the distal struts.
Yes, so from the provisional, so this distal strut is always provisional. The only thing that you need a proximal cross is crush, okay?
Crush, yes.
DK
Any crush.
Everything
Mini
else
crush,
is
crush,
different.
DK crush. Crush is only for proximal crossing. For all other techniques, culotte, tap, and all those, you do the distal crossing. And there's a specific reason for that. If we have time, I can discuss that with you as well. So you recross, and only if you only balloon it, as said, if there is compromised TIMI flow, there's dissection in the side branch after you put in the main branch stent. If you have not pre-dilated, dissection is out of the question, unless you have a very big size stent in the main branch, which the dissection extends, which is quite rare though, but the dissection won't be there. But there can be some plaque shift, which might cause compromised TIMI flow. Even if the ostium is pinched and the flow is good, as I just said, it can be a Karana shift. So you don't need to chase the side branch if the patient is doing good, ECG is fine, the blood pressures are fine. Only if the flow is compromised and the patient is having chest pain, chest discomfort, maybe signs of hypotension, the artery going down, then you recross quickly. You already recrossed at times, and you just put another balloon and you open up the struts and always finish it with a kiss.
Yeah. So if you recross, so make sure the balloon protrudes minimally to take care of the stenosis. Don't push it all the way out. So I like to have minimal protrusion into the side branch, okay?
And which balloon you prefer? Any balloon would do good, yes. So at times they say that in trials mostly they took non-compliant balloon to do this, but any balloon, as for that matter, it doesn't matter much for.
But minimal protrusion, okay?
So this is the final case. You only do that when the side branch is still persistently more than 90% stenosis with decreased flow.
So no, the kiss is not always necessary. So
Next.
you can go to the side branch, open it up, and come back with a pot, okay? So pot,
Next thing.
side branch rotation pot has probably comparable results to kissing balloon inflation.
So this is about sizing the pot balloon. So it's always remember when it comes to the coronary arteries, the Finnett's law is used. It's that the main branch is not always, never the sum of the two branches, it's always less than that. So for the pot balloon, it is 2/3 of the sum of the side branches. For example, if the two side branches are 4 and 2, or 3 and 3, 6, so 2/3 comes out to be 4. It's never 6. So always take a pot balloon size, 2/3 of the side branch sizes. It's again true for the final casing as well. The size of the casing should never be the sum of the side branches, the diameter of the side branches. It is 2/3 of the sum of the side branches. For example, the two side branches are 3 and 3. For example, just for instance, it's come out with 6, and 2/3 is 4. So you take a 4 balloon for the pot, not the sum, because it's going to cause you a lot of problems.
There's a very simple way to know this. A side branch balloon should be the same as the diameter of the vessel, but the main vessel half size it, then you come to the same conclusion.
Yeah. So this is what a pot is. This is a computer simulation. Why the pot is very important in almost all the stenting procedures now. Because what pot does, if you look at the A, there's pot not being done, so there is a gap just behind the stent struts, and your wire inadvertently can go into this and then go into the side branch, not knowing that it was. So pot is very important. Before you redirect your wire to the side branch, you do a pot. And secondly, as we discussed earlier, that the side branch pot also opens up the struts for easy re-entry into the side branch. You see in the D, the struts are very much open now, and it's much easier for you to access the side branch compared to the B, in which it's a bit of a crowded without a pot. So that is why doing a proximal optimization technique is very important. So do you routinely do pot and repot both, or just the pot?
No, I do pot and repot.
Pot and repot both.
I'm
Okay.
a big believer in pot and repot.
Okay, so that is very important. So if there's one thing that is very important that is over the period of time has come up, is the pot, and it has improved the outcomes of such patients quite drastically, quite well.
But when you do the side branch dilatation, there's some pull back of the stent stress from the opposite wall, so you have to do a final correction.
Yes. So I was telling you about the FFR. Even if the ostial side branch looks pinched and looks very much diseased, it's not necessarily that it is the plaque shift which is causing. It mostly can be a geometric distortion in case of tortuous vessel, or it can be a carina shift. And this is a very important paper which was published in 2005 by Ku et al., and it showed that among 73 sideband lesion with more than 75% stenosis after main branch stenosis, only 27% were functionally significant by FFR. So angiographically, it looked quite tight, but only 27, that is less than 1/3 of them were FFR significant in those cases. No TVR at 9 months in FFR more than 0.75 or FFR less than 0.75. Even if they went with stenting, the difference was not existent. Over a period of time, that artery tends to come back because of the increased flow, because of the endothelialization and all that process. So even if that vessel is stented, you can see that the TVR was not much different over a period of 9 months' time. So when angioplasty is performed to treat a lesion that are significant, FFR becomes a non-significant and remains so as 9 months despite a residual stenosis of up to 70%. So it's very important because most of the times it can be the carina shift rather than the plaque shift. So your sizing of the balloon is very important. You always size to the distal to avoid any plaque shift or any significant carina shift as well. So distal sidewide wiring.
So the question is, how virtually never do FFR. It's painful to get the wire to torque into the side branch. You know?
So just in study which showed in left main maybe you tend to do at times.
Yes, yeah, but very rarely.
Very rarely, yes.
If there's a good opening in the side branch, your wire will go. As all these FFR wire, whether it's from Phillips Volcano or St. Jude's Abbott, it's very difficult to try to torque.
So how do you side the side branch recross? So for the distal struts, you send it across the main branch and then you pull back and redirect?
Yeah, you have to go like a loop.
So this is what they do. Normally we do. We put the wire all the way down and just slightly pull back. And once we redirect it towards the side branch, and just at the distal strut, we tend to re-enter. So this is what we were testing. Why recross distally in provisional stenting? It's all about the morphology and all about the pattern of the opening of the side branch strut. For example, if you do it proximally, you can see on the left side, if you do it distally, a very nice conical opening is formed, which not only improves the side branch morphology and the side branch configuration with the main branch, but also helps us access the side branch stent if required properly. If we do it proximally, the stent gets distorted, and it's very difficult to put in even a stent, all that. Even if we put in a stent, there will be large metal jacketed up in the proximal side branch as well. So that is why you always go the distally.
This is from the article we published. Fadi was my fellow back in 2016. So there are a lot of illustrations, some very good tips in this particular article that we just.
So this is the configuration and all that helps a lot. Yes. So only, the question is only in crush, you recross proximally. In all other bifurcation stenting, it's better you go proximally. And again, I think you would agree with me that you never be obsessed with that, because it is one of the most difficult steps in bifurcation stenting to recross. So all the time, at times, unless you are very perfect and you want every step to be very, going on perfectly, you don't get obsessed with that. Even if you cross from the middle, not that distal, it's good enough.
But not proximally.
Not proximally, obviously. So even if you are not going distally, at times you tend to pull your back and redirect it and all that. It makes the procedure longer. It tends to make the things complicated. So even if it's not too distal, even slightly in the middle or close to distal, it's good enough, as long as it's not proximally. So that's very important that you don't get obsessed with that, because it's one of the most difficult steps of bifurcation stenting. Otherwise, all the steps are quite good and easy, but this is one of the most difficult one to recross the side branch and enter.
Once you make that hook, go to the stress and point upwards. You have to keep torquing the wire gently back and forth to straighten it to pop through, okay? Otherwise, you'll keep getting stuck on one of the walls.
Yes. So, Professor, if you have to do a simultaneous kissing balloon inflation, do you do sequential or do you do simultaneous?
So you have to, in kissing balloon inflation, you should always go with minimal protrusion but high pressure, say to 16, to make sure the stents are open at the ostium of the side branch, and then you can deflate it and go to a similar high pressure on the main balloon, but then bring it down to about 8 or so, and simultaneous diffusion.
So this was a paper that was established. It showed whether we should do simultaneously or sequential. What they normally do, that they do put two balloons of 1:1 in the side branch and the main branch, and they pull it back, as Professor said, just minimal protrusion. First of all, they do the side branch up to approximately 12 to 16, then the main branch 12 to 16, and then both simultaneously up to 8 to 10, not more than that. So sequential ballooning is considered to be better than the simultaneously kissing. So you side branch first, main branch, and then together. And it's very important to go down simultaneously. That is the most important step, because if you do one before the other, then the other stent might get collapsed from the other balloon, which is late to deflate. So simultaneously deploying both the balloons and simultaneously uninflating both the balloons is very important. So this happens if we, you can see, if we do simultaneously kissing compared to sequential kissing in E, the ostium of the side branch is quite big, and the studs are very better aligned compared to the upper ones. So other technical tricks, 6 French, do you use 6 French or 7 French for provisional?
I'm 6 French radial all the way.
Okay, so provisional is 6 French is always the way to go. And you've seen 6 French can fit simultaneously stent and balloon less than 3.5, unless you are taking big balloons. For example, left main is always a 7 French or above.
6
and
French.
6 French is okay?
Guide is pretty good with that.
Okay.
Yeah.
So
DK crush, I'd use 6 French.
okay, so 6 French is good. And to make your life easier, I think for left main, if you're starting up, you can take a 7 French, otherwise 6 French is good.
Thousands of left main, 6 French.
6 French.
The Medtronic guide is pretty good.
Okay, so for 6 French is a better option for non-left main bifurcation lesions, and you can see it will hold the 3.5 millimeter quite well, and it works for most of the bifurcation techniques, including the T, the tab, the culotte, and sequential mini crush and the DK crush. During kissing balloon inflation, be careful not to oversize in the proximal vessel. So again, the Finnett's law, it's not the combination, it's this. So never go. For example, if you take a 3 balloons, you dilate it up to 8 to 10, rather than 12 to 16. That is why we do the sequential. We go the sequential maximum in either of the branches. For example, the main branch, we go to 12. In the side branch, we go to 12 to 14, for example. But when it comes to the main branch, simultaneous kissing, it always 8 to 10, not beyond that, because it can cause problems in the main branch. So the effective side by balloon on diameter in the proximal vessel is less than the nominal diversion, as we just discussed. So the wire tipping method that you just said, I mean, you always give 2 curves, sir, for just to recross?
I do.
So it's important to give two curves. One, the first curve is based on the size on the size of your main branch and the distal main branch, and the tip that you normally give at approximately 90 degree for re-entry. So these two curves. So you push the wire downstream into the distal main branch, and you pull back and you redirect it towards the side branch. And if it is and if the studs are properly potted, for example, you have done the pot process properly, it will very easy slip across into the side branch. So this is the technique. So always remember, if you follow the techniques and the steps, you do the pot properly, you have sized the main balloons properly, and you have made this kind of tip, it's much easier for you to enter the side branch.
No, that's different, no. C2 is a very small curve. J on the wire tip, just from behind, come back behind, make another J on it, okay? You don't have to make a C2 tip. And the other thing is, if you have a loop, you know you're confident you're going through the body of the stent, not under the stent. So
this is an interesting case that we did a few weeks back. This patient has a proximal LED lesion, and if you look at the other, there's, sorry. Okay, so that's bond. They went up with tap technique. There's only one. So T and protrusion, the tap, what are the steps? You wire both, you stent. Most of the stents are that same of that, the provisional strategy. So you have wired both arteries, you have done the pot, for example, the side wire is going down, so you rewire it, you know how to rewire, you know which starts to follow for rewiring. You balloon it, you put in a stent with just the minimal protrusion, and then you...
So a little trick to that. So how do you know how much of that comes back to you? So if the marker of the stent balloon just touches the undersurface of the main wire, so the main wire is going, just barely that marker comes to that, you know you're 2 or 3 millimeters in.
That's important, yes.
Okay. And the other thing is that once you blow up the stent balloon, you need to bring the balloon back sitting in the main vessel.
So you can do, even the stent boost, it can help you as well. For example, if you have good angiographic machine available, you can do a stent boost. So this patient came with NSTEMI, so LED is diffusely diseased. So probably the first, maybe you can go for a provisional strategy, you're not knowing the size of the diagonal at this moment in time. NSTEMI patient, ongoing chest pain at time, mostly with the patient presented with. So the operator wired both, and he ballooned both just to see how it goes, because there was no flow in the side branch. So in that case, you don't have any choice.
That's the right thing to do.
Yes.
Now the second diagonal is also closed off, by the way.
Yes, close up as well. Okay. So following wiring, he placed a stent in the main branch. So the side branch was not looking good, as you can see over here. It would be with this placement of the struts of the side branch, and he committed himself to the tap technique as a bailout. So he pushed it back slightly with the struts just into the main branch. It looks good in the caudal in this view. So he deployed the stent on the left upper corner, and then finished with the case. And you may have difficulty in reascent, so you can stent it on the up, and then you can do. Among the bailout strategies, tap is one of the better ones, if not the best option. Thank you.
Thank you. I don't think I would change my strategy based on the EF, and that's more important for me, like a left main circumflex situation. Important diagonals may not cause such hemodynamic compromise, okay, in my opinion, okay? But I think I'll still continue the same steps as I've always done. I try to avoid a 2-step strategy with the diagonal because because obviously smaller vessel compared to a